everybody, if you're just joining us, we're just giving everyone a moment to find their way onto Zoom. We'll be starting in about 30 seconds. Okay, good morning and good afternoon, everybody. Thank you very much for joining us today. My name is Amanda Russo. I'm the head of media content here at the World Economic Forum, and I have the honor and privilege of moderating this session today. We're going to be discussing some very important findings, and these are from the latest report from PERC, the Partnership for Evidence-Based Response to COVID-19. And the report that we're launching today, it's the third in the series called Using Data to Find a Balance. And it was filed in February, and this was a time when I think we can all remember Africa was emerging from a second substantially larger wave of COVID-19. And PERC polled more than 24,000 adults across 19 African Union member states. And they compiled social, economic, and epidemiological data from a range of sources. And they compared the results from the previous study from last August 2020. And I think as the world is battling new COVID variants, the supply of the vaccine rollout remains critically low across Africa. The findings of this report are more relevant than ever. So some of these findings, just to kind of get everybody up to speed, there is a likely underreporting of cases across member states. Popular attitudes are covered towards continuing public health measures, and it also covers the indirect burdens of COVID. So income loss, food insecurity, disrupted access to essential medical services, all things that are very important for all of us to kind of work together towards as we enter, the latter half of 2021. So you're not here to listen to me, you're here to listen to some of our key partners here. So we have Dr. Richard Mihigo. He's the Program Area Manager for Immunization and Vaccine Development for the World Health Organization. Thank you very much, Doctor, for joining us. We also have Dr. Tom Frieden. He's the President and CEO of Resolve to Save Lives, an initiative of Vital Strategies. And then hopefully later on, we're going to be joined by Dr. Ahmed Uma. He's the Deputy Director of the Africa CDC. So some brief instructions from me as we're starting. If you're joining us on Zoom, thank you so much for listening to some of these important findings today. This webinar has simultaneous translation in French. So there's a little interpretation globe button on the bottom right of your screen. So if you select that, you can listen to me speaking in French, and also our panelists, and ask any questions that you need that way. We're going to use the Q&A function at the bottom of the chat. So if you do have questions about our remarks or about parts of the report, please use that Q&A box. For those of you joining on the phone, please email your questions to press@vitalstrategies.org. Vital Strategies is all one word together. They're going to make every effort to make sure we can ask as many questions as possible today. We know that there's a lot of a lot of you on the line. So thank you for joining. So with that, I'm going to hand over to the first panelist, Dr. Mihigo. Over to you, sir. Can you tell us a little bit more about the status of the vaccine rollout and some of the challenges, sir?
Thank you very much, Amanda. And let me first really thank, okay, thank you. Let me really thank first the organizer for this press media briefing, and particularly Dr. Tom Frieden, who has been a big supporter of public health in Africa. So thank you very much for the partnership with WHO, but also the broader partnership that has been created really around COVID-19 response in Africa. So I'm going very quickly just to give you a broad overview on the vaccine uptake in the region. Next slide, please. By starting with this graph and map that is showing where we have come from and what are the remaining steps that it needs to be done to make sure that Africa is also catching up with the rest of the world. Though vaccination started a bit late, at scale probably around beginning of March, we have seen some progress in the rollout of the vaccine during the last 2 to 3 months compared to where we were. But the journey, as I said, is still very long. As of today, we have around 21 million that has been administered, doses that have been administered in Africa, compared to close to 1.3 billion of doses that has been administered globally, which you can clearly see that there is a huge gap that has been created, and this is translated into close to 1.2 doses that have been administered to 100 people, compared to around 15.6 doses globally. In the next slide, try just on a very synthetic way, give you a broad picture on where we stand. Close to 49 countries in the region have received some vaccines. And so far we have close to 37 million doses that have been received. We do have few countries that have not yet started or even received any dose of vaccine. Those are countries that are shaded in gray in the African map: Tanzania, Burundi, Eritrea, Chad, Burkina Faso, and the Sahrawi Democratic Republic. So out of the 37 million of doses that have been received so far, 21 million have been used in 48 countries, with one country that has just received vaccine recently, Central African Republic, that have yet to start the vaccine. Close to 5 million people have received the full 2 doses in the region. So the region has also been characterized by receiving vaccine from different areas. The main source remaining the COVAX facility, where we have 43 countries that have received vaccine from COVAX. 35 countries receive vaccine from different sources, being through bilateral donation, through some bilateral deals with manufacturers, etc. On the next slide, we've tried to illustrate the ratio of vaccine that have been administered over the vaccine that have been received. So we have seen really a mixed picture with a few countries really doing very well, trying to use up all the doses that they've received. And I will come back to that. So really very good progress on some countries, and some challenges, particularly in the countries that are still struggling with vaccine hesitancy. And I believe the report that is being launched today tried not only to provide some insights on this issue, but also to try to see how propose some way forward. Next slide. So what are the challenges that we have seen? I would like to put this in the 2 areas. First of all, on the supply side. On the supply side, we've seen really, particularly with the COVAX, a lot of delays that now have been seen with the shipment of the vaccines to enable country to start administration of the second dose. We all are now cognizant of this unfortunate and tragic situation that is going on in India that has led really the COVAX supply pipeline being affected. So doses that were expected to be delivered in February, March, and April, in March, April, and May have not been delivered. We are talking about 140 million doses that were expected to be delivered in March and April that have been seriously delayed. So most of the country that started their vaccination beginning of March will reach the 12 weeks interval between the two doses around of end of May, beginning of June. And we have already countries that have used up all their doses that they've received. So a serious issue in terms of how to discuss and to delay further the administration of the second dose. So on the COVAX in particular, there are really exploring different solutions to try to see how to cope with this situation, being implementation of the dose sharing process, negotiation with other manufacturers, but this really remains a major issue. But we've seen some progress, at least the last few days, where new deals were finalized at the COVAX. This may not necessarily have an immediate impact on this to solve the supply issue, but I think these are very good prospects for the rest of the campaign. Moderna, that has concluded the 500 million doses deal with COVAX, Novavax as well. And we're starting to see some progress. Things are starting to move, particularly on the strong appeal that was launched by the WHO and COVAX in dose sharing. So few countries, France, Sweden, New Zealand, but we are also seeing other countries joining the movement to share some of their doses. And the recent announcement by the US to support the TRIP waiver, I think opened also a lot of opportunity in terms of local vaccine production. And there was a very, very well-attended consultation that was organized by Africa Union a few weeks ago on how to fast-track local production of vaccine in Africa. And on the other hand, we are looking at how to increase the pace of vaccine rollouts by supporting countries in increasing their preparation, balancing the vaccine hesitancy, particularly in groups that have been targeted with the willingness of some group age to receive the vaccine, as well as trying to address the issue of lack of operational funding that has really hampered the rollout of the vaccine. And then to conclude, I would like to, next slide please, to mention the work that is really being done to set up what we've called the Africa Emphademic Response Alliance, which is a multi-stakeholders partnership that WHO is leading to make sure that the rumors, the misinformation that are widely circulating in the media and the social media in particular can be debunked. So I'd like here really to thank all the partners that have come together to work to pull together this Emphademic Response Alliance, and we have starting to see difference on the ground. I would like to stop here, Amanda, and we'll be more than happy to respond to any further question during the discussion.
Great, thank you, Dr. Mohigo. I'm sure there are going to be a couple of questions as we continue onwards later in the Q&A portion of the meeting. But I'm going to turn now to my other presenting colleague, Dr. Frieden. Thank you so much for joining us. I would kind of like to turn things over to you, sir, and tell us a little bit more about, the context and about some of the underlying challenges that you're seeing here, and some of the, your views on what is really important on focusing continuously on COVID-19. Over to you.
Well, I think the bottom line with this PERC report is that the burden of COVID is under-recognized on the African continent, or the world under-recognizes the burden that the African continent is facing from COVID. This is a burden from COVID itself, which has been underdiagnosed and underreported because of a variety of reasons, including the lack of access to testing and the lack of access to healthcare. Second is the burden of non-COVID health conditions that have gotten worse because of the disruption that COVID has caused. And one of the things that this report highlights is that more than 40% of people skipped a medical visit or didn't fill a prescription or had difficulty getting medications because of the pandemic. The third are the economic impacts, and the fourth are the social, and the fifth are the nutritional impacts. So we're seeing a huge burden of COVID in Africa, despite a misperception around the world that Africa has been relatively spared. There's more COVID than has been recognized. There are many more non-COVID health problems than have been recognized. And this report emphasizes the economic, social, and nutritional challenges. I think we have essentially a tale of two worlds going on, a world where vaccine is crushing the curve and beginning to usher in an era of a post-COVID reality in many countries around the world, including the United States and others, and a world where vaccine remains many months, if not even years away, where we're facing the risk of explosive outbreaks with new and deadlier variants, as we are seeing today in India, Nepal, and elsewhere. I want to spend a moment about the non-COVID health problems. Because of the high burden of infectious diseases, Africa is particularly vulnerable to these non-COVID health problems. If we take two examples in particular, malaria and measles, these are at risk of getting much worse and resulting in the deaths of tens, if not hundreds of thousands of children in this year and the next year. This is because malaria already kills nearly 400,000 children a year in Africa. And if bed nets or rapid treatment become less available, you will see a big increase in deaths, unfortunately. Similarly, measles continues to kill nearly 100,000 children a year, largely in Africa. And if vaccination programs and campaigns aren't able to be continued at full force, the risk is that they will have an increase in cases and deaths. I think we face an uncertain future, but a future about which we can do quite a bit. First off, what's uncertain is how the virus will continue to adapt to humanity. What we're seeing is the evolution of variants that spread more readily and that may be more deadly and that may evade some of our vaccines. We also must adapt as humanity. We must work together more effectively. We must ensure that we collaborate globally, that we share lessons. We also have to not neglect the key measures that will limit spread while we roll out vaccination globally. These include masking, particularly indoors, and avoiding super spreading events, large gatherings, lots of travel, lots of people indoors in one place, singing without masks indoors. There are certain things that we know can trigger explosive spread of COVID, and we need to avoid those. We also need to vaccinate. And I want to spend a moment on this. I was really struck by our colleague's presentation from Africa. 21 million vaccinations given in Africa to date. That's about the number given in a week in the US with less than half the population. This is ethically unacceptable. The world must provide more vaccines to Africa immediately. In addition, in the medium term, we need to scale up manufacturing. as rapidly as possible with all of the effective vaccines available. We're particularly impressed by the mRNA vaccine technology. This was created with taxpayer money in the United States and significantly in the EU. And this is a global public good which must be shared. The mRNA technology results in vaccines that are easier to tweak against variants, less susceptible to production delays of the other vaccine production methodologies, and can be rapidly scaled up globally, including in Africa. There is a deep and tragic irony about the data that we're sharing today. We're seeing vaccine hesitancy in countries that have ample vaccine. And we're seeing an eagerness to get vaccinated in countries that don't have sufficient vaccine. We also need to think about being strategic with vaccination. There are several million healthcare workers in Africa. They should all be getting vaccinated urgently, and countries should track what proportion of their healthcare workers have gotten vaccinated. That's important to save their lives because they are at risk, to protect their families and communities, and to protect healthcare services. Because if healthcare services are seen as being safe, people will continue to attend, the health workers will continue to go, and the secondary health impacts, whether measles, malaria, TB, HIV, or others, will be minimized. And of course, we need to improve treatment, including the availability of oxygen and dexamethasone. I'll stop with one concluding thought. Many of the countries in Africa have very structured, organized responses to COVID. And this is something that every country needs, an organized response using an incident management system, basing on data and communicating in an open and transparent way with the public. That kind of open, transparent response can minimize the burden by balancing our implementation measures with support measures for communities. And it is, again, ironic that many countries in Africa are quite experienced and quite effective at running vaccination campaigns, but we have not enough fuel in the tank, not enough vaccines to be given. At this point, we have to focus on vaccinating healthcare workers and older people, people over 60 or over 50, because that will have the maximum impact, reducing the burden of hospitalizations and deaths. But urgently, we need to provide more vaccine to countries throughout Africa. I'll stop there and look forward to the conversation.
Thank you very much to both of my speakers. Just a reminder to those in the session with us today, if you do have questions, drop them into the Q&A in the chat box, and we're going to get to as many as possible. I'm going to start stuff off, one that's kind of come in through email, and also one question that I've had for both speakers is, can we talk for a second about India? It's very tragic what's happening there. The news reports are very sobering. What are you seeing there, and how are some of the lessons learned? What are you applying across Africa? Dr. Mihigo, I would love your views on this, but maybe we'll go to Dr. Frieden first. Sir, tell us a little bit more about India, and then we'll hop over to you, Dr. Mihigo. Sir, you're on mute.
What we're seeing in India is tragic. We're seeing explosive spread of a newly recognized variant of COVID with very high rates of hospitalization and death. Anecdotally, we're hearing about reinfections with people who were vaccinated with the AstraZeneca vaccine, but those appear to be less severe. We've also heard about similar reinfections in at least 3 other countries, Seychelles, Mongolia, and Chile, from different vaccines. But the emerging data suggests that although vaccines may not protect as well as we would wish against infection with the new variants, they appear to protect against death. We don't know how well, but that appears to be the case. There are a few lessons that are important for every country. One is to have an organized response so that you have a clear line of command, a clear war room approach that has different components, including the strategic use of vaccination, the strategic use of data, the optimization of existing medical supplies, and the effective communication with the public. What we're seeing is in parts of India, very effective responses. For example, a system in Mumbai to prioritize oxygen and make sure that the existing capacity is optimally used to save as many lives as possible. We're also seeing some states take action to limit spread. It's very important to recognize that vaccine is not going to make an immediate difference when there's explosive spread. That's because, on one hand, there isn't enough, but even if there were enough, it wouldn't rapidly curtail cases. The only ways to curtail cases rapidly are maskings and closures. It's also very important to look at mass events where people travel to one place. Travel is a way, unfortunately, of accelerating spread of the virus. The way to think of this essentially is that it brings spread to the highest common denominator of the different areas. So I think the main lesson from India is never underestimate this virus. It's a deadly virus. It's continuing to learn and adapt. And if we let down our guard, we could face a catastrophic situation. I think it's in particular a warning for India, for Africa, a warning for Africa to get your healthcare workers vaccinated with the limited vaccine you have, to get your elderly vaccinated on priority, because that will maximize the impact of the limited number of vaccines, to mask and to limit rapid spread, and to continuously use data. And though I said it was the last point, I'll make one other point, which is that the time we have to react has gotten shorter, because the new variants are even more explosively transmissible. They're even more rapidly spreading. Where we might have had 2, 3, 4 weeks before, we may only have about a week now. So if we see the beginning of an upturn, we may need to rapidly ratchet back on connections that expand spread while we protect the social safety net to the greatest extent possible, allowing, for example, outdoor markets without limitation, because that will be safe. So we've learned better how to adapt to this virus, but we need to continue to learn.
There's a lot going on. Dr. Mohigo, over to you.
Yeah, no, thank you very much, Amanda. I was really following with interest what Dr. Frieden was saying, and we do really hear WHO share those points. Clearly, we are following up quite closely the situation in India. As it has been described, this is something very tragic that everybody would like to avoid. If we look back a bit, few months ago, Africa went through a second wave around the Christmas and New Year period, which exactly coincided with the mass movement of population around the Christmas period. And we went through that quite intense second wave, almost in all the countries. And one of the lessons that we've also learned, that the second wave that we went through in February, in December, January, February, was much bigger than the first wave that we saw a country going through in the summer last year, June, July, etc. So we are really starting to work with countries to prepare for the worst, because we don't want to have a third wave that will be generalized, that will be definitely more deadly than what we've seen in the second and the third and the second, in the first and the second wave. And to do that, I think we are looking at some of the critical area, notably to try to understand what the drivers from what is currently going on in India, and most of them have been very well described by Dr. Frieden. and then try to see how country can be very well prepared to respond to that. Number one, I think we saw many people, and particularly in this continent where vaccine rollout has been not yet being optimal, really to stress the fact that the public health measures, social measures that have been quite very rigorously applied in many countries at the beginning of the pandemic in Africa, and which really prevents many spread. I think indeed there is a fatigue, and the report is highlighting this very well. But I think those measures are still valid and more than ever to save lives today. Secondly, I think we discussed the issue of preparing for particularly case management for those who are the forefront of this response. Healthcare workers, community healthcare workers. These are the people we are really relying on to make sure that surveillance do work, cases are detected. And even though the testing capacity and testing rate is still very low in many countries, but having a very well organized community-based surveillance system, which can at least detect cases, help to manage those cases quite very well at the community level, I think will make a big difference. And then finally, if at all people get to go to the health facility, to make sure that what we've learned from the last 12 months in terms of improving the processes in hospital, making sure that the tools to deal with the outbreak are present. We talked about the dexamethasone, oxygen is present to avoid what we are currently seeing in India. I think it is that web of action that are currently needed to make sure that Africa is not going to a third wave that will be more deadly than what we've seen so far. And to conclude, vaccines here will have a critical role to play. I think we need to re-emphasize that. And the fact that many countries with the very few doses that they've received have prioritized really healthcare workers, community healthcare workers. I think was a very, very smart decision, as well as the some of these priority groups that are more likely to get severe disease and end up in the hospital. Now, what will remain to be done is to make sure that the remainder of the people can get vaccines as soon as possible. Thank you, Amanda.
You're welcome. We have a couple of questions that have come in, one from South Africa, one from Uganda. A question from one of our South African freelance journalists, Marcia. She is saying South Africa has confirmed cases of one of the variants, yet there's also close to 500,000 vaccinated healthcare workers. Are either of you concerned about a potential surge of cases in South Africa? Dr. Mihigo, can we start with you on that question?
Sure, absolutely. South Africa indeed went through a second really wave that was quite important with the detection of the variant that was first, of course, detected in South Africa that end up to be more transmissible to the population. And I think what we saw in South Africa really was the way they managed to deal with this second wave. And we've seen that they managed to bend the curve. The cases are now going down, despite, of course, the wide circulation of the new variant there. Just saw this morning some press release in Durban where people are now queuing to receive vaccine, which is something really breaking, because people, what we discussed before, the eagerness of the people to get vaccinated it's really there. So I believe that with the ramp up strategy that the government has taken to expand the reach of the vaccination with the Johnson and Johnson beyond the Sisoke sites, but also the imminent arrival of additional doses in South Africa, notably through COVAX with Pfizer vaccine, but through as well the government that has procured, make some bilateral deals with Pfizer on that. I think we hope that the ramp up capacity to vaccinate more people will help to contain this spread of the virus.
Dr. Frieden, welcome back. Any comments on South Africa? We do have a couple of other questions that have come in on what the media can do, so we'll address those next. But thoughts on South Africa, sir?
I think we're going to have to see. The fundamental question is what's going to happen if the variant first identified in India enters areas where there is some level of vaccination. And I think that's going to be of concern, not just for healthcare workers, but for all societies. Is this going to create or drive another wave? We don't know the extent to which different vaccines will protect against different variants. This is another example of why it's so important to have real-time data to make real-time adjustments to our responses. And that's really the essence of what the PERC partnership is about, getting real-time data, sharing that with governments, and working to optimize the response.
So I want to talk for a second about vaccine acceptance, what the media can do to kind of help communicate trusted messages, the facts, science. I know the WHO has done a lot of work putting out information, making it easily accessible across different languages. But let's talk about countries. So I know there's Morocco, there's Guinea, there's Uganda. They have a high percentage of vaccine intent amongst their population. Why is that? Why are we seeing these trends in these countries?
So let me say, maybe comment globally first, and then Dr. Mihigo can comment on the Africa context. You're seeing a big variability there, but I would emphasize that most countries, you have a pretty high level of intent. What we see is that there is a lot of lack of information. People just have not been informed about the vaccine. And frankly, without vaccine being available, you don't want to create demand before there's supply, but you do want to address disinformation and misinformation. But I will say, globally, we see a tight correlation between trust in government and trust in vaccines. So where there is more skepticism about the government, there is more skepticism about vaccines. That's not a complete correlation, but it's a general correlation that we see. Dr. Mihigo?
Yeah, I will concur with that, Dr. Frieden. But maybe just to add that clearly the way some of the country handled the issue related to the vaccination and the response created its own challenges to create that trust and perception for the value of vaccine. But I might say that overall, in many countries in Africa, vaccine acceptance is quite very high, very high. I'm talking about routine immunization services. We have seen indeed some issues in a few countries, but again, we need to just to look at this data with a bit more of cautious, because if I take a country like Ghana, where we see 58% vaccine intent, Ghana for the moment is almost the champion in West Africa in rolling out the vaccine. They've used up almost close to 1 million doses that the country have received. And every day we are getting requests from Ghana for more doses. So I think there is this, what I mentioned in my introductory remarks, how to balance the perceived vaccine hesitancy with the eagerness of population really to receive the vaccine. And then that's exactly what we are seeing translated in some countries, where when vaccines is being offered to the people, people are queuing to get that vaccine. But we should not minimize, indeed, some of the real problems that we are seeing in countries. The example of DRC is very well, it's very interesting, by the way, because we did send back almost 1.3 million doses of vaccine that came through COVAX because of the country inability to roll out this vaccine before they are expired. But at the same time, 2.5 weeks ago, we supported the launch of a mass preventive vaccination campaign against yellow fever. And surprisingly, people turn out massively to receive the yellow fever vaccine because depending on the way things are being presented, etc., this was in 7 provinces. We were targeting 16 million of people. And just the first 2 days, quarter of a million of people were immunized against yellow fever, whereas there was some struggle to roll out COVID-19 vaccine. So I think all of these are elements that we need really to put into context locally, and then to see how we can better support countries to build that trust.
And maybe let's talk about that trust as the closing question that we have here. You know, building trust, countering misinformation. What are some of the top things that you both hope to see in the coming 3 months? Dr. Frieden, what do you hope to see?
Well, for building trust, I think what we need is very clear communication with the public. I think South Africa has done a very good job. Ghana has done a very good job. And that includes telling people what we know when we know it, being clear about what we don't know, and being frank about how we're trying to find that out. I think we're going to have very rapid assessment of whether explosive spread is going to be happening. We're going to have to double down on masking and preventing spread when that occurs, and do strategic vaccination of healthcare workers and the elderly to limit the harm. What I'm hoping is that we don't have the kind of vertical graph, rapid explosive increase in Africa that we're seeing in other countries, but we cannot let hope be a plan. And building trust means, among many other things, and perhaps most importantly, communicating frequently, openly, honestly, simply, plainly. And that kind of effective communication may include giving a sense of the level of risk in each country, province, or state, adjusting that regularly as more information is obtained. The more we can inform people, the more they can protect themselves, the more we can balance stopping COVID with not stopping healthcare, and with providing support for communities, families, and individuals for their health, for their economic, social, nutritional, and educational development, the better off we'll all be. Thank you.
Dr. Mohigo, you know, the same question 2-3 months from now. What are some of the measures you're hoping to see in terms of building trust, countering misinformation?
Well, on top of what Dr. Frieden has mentioned, I think we need also at the macro level to see how some of the international commitment that has been made to countries, and I'm looking here at the supply and the quest for global solidarity in providing vaccine to the people who need them, I think needs to be fulfilled. We have serious issues now in countries that delayed of the second dose, putting a bit that trust in question. And while people are watching other places, vaccine to be continued to be rolled out. And I think it's really created that sense of, are we in the same boat? Are we going to end this pandemic in every places and all together? I think it's very important, particularly that we have now passed 1 year after the COVAX has been established, that I think we renew our commitment in that, so that people can trust when we say next vaccine batch are going to come and etc. Secondly, I think it has been also alluded to by Dr. Frieden. I think we are seeing now people trying to say, okay, we need as well the non-COVID health problem need also to take precedence. We don't want to be in a place like what we saw after the Ebola outbreak in West Africa in 2014-15, where explosive measles outbreaks, for instance, occurred in the 3 countries that were most affected, Liberia, Sierra Leone, and Guinea, after the people attention were mainly on Ebola alone and not on some of other broader health system issues. And then I think finally, bringing community, bringing the beneficiaries on board to be as transparent as possible. And I think the report tried to bring some of these elements to the fore. I think all of that element will definitely help us moving forward. Thank you, Amanda.
Well, I mean, I think we can all agree there's a lot of work that needs to be done. So hopefully some of the key findings in this report can help direct some of our leaders out there to move things forward as quickly as possible. So I'd like to just thank my speakers. Thank you for sharing your thoughts and your outlooks for the path forward. The report is now widely available, so if you want to go and learn more about some of these social and economic impact areas, please do check out part 3. There's also a very big section on the need for vaccine equity. I think we were all a little bit shocked at some of the numbers. I mean, 400,000 from malaria, 100,000 dead from measles. Those are staggering numbers that I think, you know, moving and keeping in mind, it's not just COVID-19 that's impacting a lot of people. There's a lot of additional things that need to be done. Thank you so much for participating. If you do have further questions, we'd of course be happy to answer them as best we can. That email address on screen, press@vitalstrategies.org, is the way forward. So thank you very much for joining, and thank you very much for your questions.
Thank you all.
Thank you. Okay, bye-bye.